Hello doctors, welcome to Chennai Women's Clinic and Scan Center's Dialogue Series. This is a part of our initiative to leverage technology to best serve medical community through healthy debates and discussions. I am Dr.Deepthi Jammi, Consultant Fetal Medicine at Chennai Women's Clinic and Scan Center. Today we have with us young eminent gynecologist from Chennai, Dr. Nithya Ramachandran,
Hi.
who is a postgraduate from Government Medical College, Kottayam, who is currently practicing at SIMS Hospital, Cloud9 and Motherhood, Chennai. Her special interest includes endoscopic surgeries. We have Dr. Kritika Kaushik, who is postgraduate from Bangalore Medical College and Southern Railways headquarters. She is currently working at Jain Hospitals and Cloud9 Chennai. Her interests would include high-risk obstetrics. We have Dr. Anusha Raj, who is a postgraduate from Institute of Obstetrics and Gynaecology, a part of Madras Medical College. She is currently practicing at SIMS Hospital, Medway, and Cloud9 hospitals. Her special interest would include endoscopic surgeries and high-risk obstetrics as well. So today we're going to talk about a very common topic we come across in our day-to-day practice: obesity. Obesity, I don't have to actually stress, it's one of the commonest healthcare problems in all age group, especially in a reproductive age group. I'm sure my panelists would agree about it. It's such a common problem that implications which are relative to pregnancy are often ignored, unrecognized, or even overlooked because we don't have much of evidence-based data supporting the same. Having said all this, Dr. Anusha, how would you actually classify overweight and obesity? Can you just explain to us?
Sure. Let me just brief on how WHO is classified according to BMI. Anybody whose BMI is less than 18.5, they are classified as underweight. 19 to 24, they are normal weight. Overweight category is between 24.9 to 29. And anything above 30, they become obese. And in obesity, we again have three classes. Class 1 is 30 to 34.9, class 2 is 35 to 39.9, class 3 is more than 40. Why we have classified into three classes is, depending on the class they belong, the risk also becomes low risk, intermediate and high risk. Anything above 45 becomes morbid obesity.
We spoke so much about obesity. Anu, 2 days ago I consulted a pregnant mother whose BMI was 35. How would you counsel such patients? What do you think are the risks that are increased in a mother with high BMI?
Before we talk to the patient, we need to keep certain things in our mind, that we are dealing with a very, very special patient. We need to get that emotional connect with the patient. We have to realize that every simple ailment of pregnancy is exaggerated in them. Say gastritis, it is exaggerated in them. Constipation, I have seen patients with carpal tunnel syndrome, especially obese patients. They come with carpal tunnel syndrome. And recently we delivered a patient. Of course, she conceived with IVF, but her BMI was somewhere close to 40. She had impetigo, which became cellulitis, and she had a tough time with this. So all these skin and complications, dermatological complications, are also more common in obese women. Apart from that, we come across vitamin D deficiency, and most common maternal diseases are gestational diabetes, preeclampsia, gestational hypertension and preeclampsia, thromboembolic disorders, obstructive sleep apnea, that is very common in obese women. And apart from that, in our routine day-to-day practice, when we draw blood, phlebotomists they find it very difficult to draw blood for them. So when we ask for investigations, we need to ask for all investigations at one shot. We cannot keep pricking them again and again.
That's true.
And it becomes a dry tap.
Yeah. So Anu, you've told us all the medical complications. So can you tell us what clinical difficulties do we face in our day-to-day practice when we examine women in our antenatal OPD? Exactly. In the obese women.
See, when we call them for antenatal visits, we call them, one, to examine them, to check their medical condition. Second thing is to examine the baby and check the fetal growth and well-being. See, first thing we do is check their weight. We need to make sure we have the accurate weighing machine. We have weighing machine that accommodates them. You can't have a small weighing machine and keep having errors when checking weight for them. And when you check their BP, you need to have the accurate and correct cuff size that will measure the BP. And when it goes to fetal well-being, there we have a problem, and that is when we seek a fetal medicine, and we have Dr. Deepthi, who will just tell us about what are the difficulties and how she will help us in assessing in examining the fetus.
Yeah. actually brought out certain points very clear, because the first main thing is we forget everything in our practice. The emotional connect is very important, because the whole family, the patient, they're all excited at one point, but at the same point we will have to put them down saying that you are overweight, which is actually very hurting to the patient. And even when they come for scans, they feel really their self moral is very low. So it's very difficult. We need to spend time. I think we need to understand them first. We need to spend time counseling, even for scans when they come. We actually get them in. See, nowadays this ultrasound machines, the technology has improved so much. So we actually use liberal use of transvaginal ultrasound in such patients. We're okay in the first trimester, early pregnancy and first trimester, because with the use of transvaginal ultrasound, we're able to catch the fetal anomalies as early as in the first trimester as well. And you also said the medical disorders are common. So if she's already a pre-gestational diabetic, obviously I'm going to rule out a cardiac anomaly or a major cardiac anomaly as early as in the first trimester, ductus and NT and all that. So first, early pregnancy and first trimester, my main calc will be a transvaginal ultrasound in these patients. If my transabdominal ultrasound is not going to give me much information. And even before performing a transvaginal ultrasound, they need complete counseling. And after that, in first trimester screening, I actually want to bring out two common points we face. The analytes which we use, the biochemical analytes, that's the serum beta HCG and PAP, they vary considerably in an obese mother. We need to have that also and go, because the false negativity of Down syndrome is higher in an obese mother when compared to a normal BMI mother.
Okay.
And also in a non-invasive prenatal testing. See, we nowadays NIPT is like on the go. It's increased a lot because we have a lot of IVF pregnancies. The patients are actually on bed rest most of the time, either because they are in risk factors or they are asked to take a bed rest because of other complications. But when we come across such patients for non-invasive prenatal testing, even before the blood sample is drawn, we actually counsel them. See, your BMI is high, and what we are trying to test in an NIPT, that is non-invasive prenatal screening, is that the amount of fetal fraction in your blood. So, if that gets diluted in your blood, the sensitivity of your Down syndrome screening also reduces. It's not going to be again 99% like how it's going to be for a normal BMI mother. So, all these points have to be put across in the initial trimesters of pregnancy. When you come, the most difficult part is when you come to the second or the third trimesters, because second trimester everyone will want to see the baby, they'll want to see the structural anatomy. There comes a very difficult point.
Sorry to interrupt, Deepthi. Let us make it clear whether we are going to offer FTS or we are going to offer NIPT, or it is the same that we offer to any normal BMI woman. Can we just put it across the table?
Yeah, see, high BMI is not a restriction for FTS. So we're not going to deny them FTS. That's not the idea here. So they are going to go through as any other pregnant, normal pregnant woman. So the first line of management is going to be a first trimester screening, no doubt at all. But in case they are more than 37 years, 38 years, like how an elderly gravida would be, then we would give them the option. But at the same time, we would take it with a pinch of salt. NIPT or a non-invasive screening is going to be difficult because the fetal fraction we will know only at the end of the test. So we have to tell them, see, you do have chance that it might go wrong. You can have a failure in the test. We might not get enough fetal fraction to report a non-invasive prenatal screening. So far, since there are no particular guidelines for us, first trimester screening is going to definitely be the mainstay of protocol. So there is no change in that. They are going to be monitored as a routine patient. And when they come back to us for a second trimester screening, second trimester, say anomaly scan, which I meant, that's also going to be a routine screening. But then for us, the difficulty do exist. Technically, it is definitely challenging to find out occult anomalies. Say we will, I have even faced situations wherein it's very difficult to see the kidneys. We actually switch on the color, we do transvaginal ultrasound even that time when they are in second trimester. But somehow we make it a point that we try to rule out major structural malformations by 19 to 20 weeks. In case, if it's very difficult, say cardiac anomalies or anything we want, we definitely would like to call them back for a 2 to 3 weeks later, probably a 24-26 week fetal echocardiograph or even a detailed targeted anomaly scan after 4 to 6 weeks. So we do it in plenty of patients who are BMI more than 35 or 39. We call them back at 24 to 26 weeks when we want to reassess the structures again, because the sacral tapering is well seen. the kidneys are well visualized, and the heart slightly grows bigger, so it makes his
Right.
job a little simpler. The third trimester ultrasound, I know that you rely on us because it's very difficult to identify the fetal growth. At the same time, even we find it difficult, and we try to give our best with the plus or minus a few 100 grams variation as our software provides. So the surveillance per se is not going to make any difference. It's going to be as a routine surveillance. In case you wish to send the patient to us within like 4 to 6 weeks gap for the fetal growth, we go ahead with the fetal growth scans. Per se, for an obese mother, no extra scans unless and until specified by the obstetrician.
Just one question,
Yeah.
Dr. Deepthi. Suppose if she is an increased BMI with multiple gestation, how different is the FTS for these patients?
Yeah, actually, it's a good question. We have multiple factors governing here because we have a high BMI, we have twins. Again, we will go into the details of twins, whether the
Okay.
chorionicity, whether it's a dichorionic twin or a monochorionic twin. So that's what is going to make a difference. Obviously, the protocol is going to be first trimester screening. And one more thing which I want to make clear is that twins, the best part is first trimester. Please don't
Right.
send them for screening for a second trimester, because obviously the alpha fetoprotein, everything is going to be doubled in twins. So if they have missed a first trimester screening in case of twins, I think we are deviating from the topic. In case they have missed a first trimester screening, please stick on to the age-related risk and the NT and nasal bone risk. Don't send them for a quadruple or a triple test. Triple test is out of the market now. It's only quadruple screening.
Test, okay.
And first trimester screening will definitely be the mainstay for obesity and twins in case. But otherwise, the routine role of management doesn't differ much. Obviously, the fetal surveillance is going to be the same, like how is any other twins.
All right.
I'm pretty sure it will change with the obstetric complications. That's when the management will differ a lot.
We've gone a bit away
Yeah.
topic,
Yeah.
but well, thank you, Deepthi. That was practically very, very important. Anusha, so much about diet in a mother with normal BMI, in a mother with high BMI. Especially diet plays a very, very pivotal role in a mother with high BMI. How would you go about giving dietary advice to your patient with a high BMI?
Okay. When we are talking about dietary advice, we need to tell them how much weight they can gain.
Yeah.
There is definitely no consensus on rate of weight gain specific to each trimester in pregnancy. But I'm sure there are evidences that suggest that so much weight can be gained depending on their BMI. Somebody who's underweight can be liberal and can gain up to 18 kgs. Starting from 12 to 18 kgs they can gain. A normal BMI woman can gain up to 11 to 15 kilos. Somebody who's overweight should restrict to 6 to 11, and obesity, irrespective of the class, they will you can allow them to gain somewhere between 5 to 9 kgs. Apart from this, I would like to stress upon that they should be taking 5 milligrams of folic acid like any other high-risk mother.
Okay, Anu, we screen women, normal BMI women for diabetes. So how different it is for women who is morbidly obese or in class 2 or class 3 obesity?
Yeah, that is very, very important because we are looking at somebody who is at risk for gestational diabetes here. What we do is at the booking visit, we subject them to a 75 grams GTT. If it is normal at that point, we again subject them for a GTT again at 24 to 28 weeks, and then we take it from there.
Right.
So with the woman more than a risk factor, say they've had medical complications, what is your role on aspirin, Dr. Anusha? Would you?
There is definitely a role on medical intervention with aspirin. See, it is like obesity with one or more moderate risk factors. By telling moderate risk factors, I am talking something that is connected to their age, that is age more than 40, their weight, which we've already spoken about with respect to BMI, and whether it is a first pregnancy, history of preeclampsia in the previous pregnancy, and whether it is a multiple pregnancy and other medical complications. All these patients, we will medically intervene by starting them on 150 milligram of aspirin. And one practical point I want to add here is the idea of starting aspirin is to prevent complications like stroke, any thromboembolic complications. So it is better to take it at bedtime because most thromboembolic complications occurs early morning at dawn.
Yes, and any mother with high BMI has to be offered risk assessment. And the risk of venous thromboembolism in a mother with high BMI is definitely significant. Accordingly, we have to offer her antenatal and postnatal thromboprophylaxis adequately depending on her weight.
And I would like to stress upon that risk assessment should be done at the booking
Booking
visit.
visit.
Yes,
All right.
you're
We
right.
all agree.
We all agree
Yeah,
to
yeah,
that.
yes, because we know when she is entering our room, when she's entering your room, either for scan or for a consultation, we all know that
Right.
we're going to deal with a high-risk mother. So no doubt about it. Yes, the points which we want to convey is that, as Dr. Anusha rightly pointed out, risk assessment, we all know that we are going to deal with a high-risk mother, so we need to rule out whether she's going to have any associated medical complications like diabetes or pregnancy-induced hypertension, hypothyroidism, and other complications. Apart from that, once we rule out the medical risk factors, examination, practical points of examination, like how she gave a tip, like write all the blood tests in one go, because the patient cannot be pricked twice, the phlebotomy is going to have a problem. So all these are few important points, because we deal with these patients and very commonly nowadays, probably it's because of ART pregnancies, or we don't know, even if we don't advise them bed rest, they are so scared that they take bed rest, and they are so scared to even go for walking for 20 minutes. Wouldn't you want to add on a physical activity for such patients?
Yes, of course.
Physical activity
There
and
is no restriction of physical activity.
Yes.
They need to be as active as possible. Apart from that, I generally advise 45 minutes of active walking.
Okay.
Only when there is a restriction for physical activity, like as we discussed already, we've discussed previously about shortened cervix and cervical lengthening and all. If there is an indication for shortened cervix and there is a stitch in, probably rest for 3 to 4 weeks, that is essential. After that, they have to do their daily course. They need to be as active as possible.
As long as they don't have a placenta previa documented. So that's the only thing
That's the
we
only thing.
tell them to take bed rest. Even then, I see a lot of patients who are absolutely normal even with placenta previa. So complete bed rest, I think it's there's no current evidence, and I don't think anyone of us practice complete bed rest. And yes, I don't have to actually stress about the limitations of ultrasound. We do tell them with we take it with a pinch of salt, because the occult anomalies, I wouldn't say missed anomalies, I would say anomalies which are very difficult to identify in such patients. I even remember a long time back when the ultrasound machines were not this high-end technology, we were finding it really difficult to identify the kidneys, like how I pointed out. We had actually seen her during 18, 19 weeks in high BMI mother, and then we actually could identify one kidney at 26, 27 weeks. The other kidney was in the pelvis. So obviously there are surprises which are thrown to us at third trimesters, and I think we will have to counsel them. I think the key is counseling these mothers.
Exactly.
When they are counseled adequately, see, pregnancy is a phase that lot of family pressure will be there. You have to eat more. At this point, I think counseling is more along with the family, not only the couple, because they should know that they can't gain weight more than this, which is harmful both for them and to the developing baby as well, and becomes difficult during pregnancy and delivery, because postpartum we are going to stress on thromboprophylaxis, either in the antenatal period of 150 milligram of aspirin at night, and even to prevent postpartum venous thromboembolism. So you heard it right. We want to just sum up, because we are coming up with a lot of patients with raised BMI and a lot of complications which we encounter. So if you want to know more about this and more information, please log on to www.chennaiwomen'sclinic.com. You can subscribe to us at Facebook or Instagram or YouTube. You can WhatsApp your queries to us at 733-8771-733. Thank you.